The next on stage will be Dr. Saud Ahmed.
Obstructive. A very good afternoon to one and all. At the outset, I would like to thank Dr. Shankar, Dr. Tabriz, and the entire organizing team for inviting me to this wonderful sleep conference. And looking at the way things have been organized and a jam-packed audience itself speaks about the success of today's program. I am Dr. Saud Ahmed. I am based out of Bangalore. I am a consultant ENT surgeon with special interest in skull base, snoring, OSA, and allergy. Before I start, I would like to acknowledge and thank all my dear teachers, my mentors, who have worked hard for us to be here and speaking on the dais, shoulder by shoulder. It would be really unjust if I do not mention the great institute through which I've passed through, which is a few kilometers from here, which has played a very crucial part in what I am and what I'm delivering today. I'm attached to, we have our own surgical center called Excel ENT Hospital, and I'm attached to Manipal Hospital, Millers Road branch. I'm heading the charitable unit at HBS Hospital, and Shishuka Children's Hospital is where we are attached for our pediatric sleep. We have a pediatric sleep OPD there, and we do a charitable clinic in association with Rotary. So I was just going through this terminology. I don't know how many of here in the audience knows about this entity called sleep divorce. How many of you are aware of this? Excellent, you're aware of this. And I'm sure, yeah, people in the sleep circles would definitely know. So when we're just talking about AHI and thinking about how we can improve our AHI, this short talk of about 10 to 15 minutes duration is to get us out of that box and make us think in a holistic way and look at parameters which will tell us that the patient is actually benefiting from whatever intervention. We had a wonderful talk by the dental colleague. So whatever intervention we are doing, how much of impact do we actually make on the individual? So isn't this an impact that we can do? It's not AHI. So we are trying to bond families together, we're trying to bond couples together. The kids are horrified by the terrible sounds of snoring at home. So we're trying to bond them together. Isn't this a success? Trying to prevent road traffic accidents one way or create more trauma units across the highways. Yeah, so prevention is better than cure. This is a way. This definitely is a positive impact. We don't talk about unemployment. We don't talk about an efficient workforce as much the West talks about, as much it's spoken on in the European countries and European platforms. So when you're looking about economic growth, when we're looking about productivity, when we're thinking about stronger workforce, don't you think we can make an impact by treating OSA? What about the reduction in stroke, reduction in cardiovascular events? So there's much beyond just AHI. And what does research tell us? It tells us that there is a significant discordance between the levels of AHI used to denote outcomes of therapy and real-world clinical outcomes such as quality of life, patient perception of disease, cardiovascular measures, and disease burden and or survival. So I'm not going to talk about what is AHI because we are at kind of the fag end of the conference. I'm sure all of you know what is AHI. But we need to know that it can vary from night to night. You do run 2 sleep studies on 2 consecutive nights, you will find there is a discordance in the AHI. It can vary from device to device, lab to lab, and from the kind of transducers that are used. It can vary in terms of the algorithms, as what algorithms, because nowadays all this is automated. You run a sleep study and you get a ready-made report. So now it depends on what algorithms that device uses to give you that AHI number. So this is a classic that everybody in the sleep circle should know about Sher's success criteria. And according to that, it is a success criteria for a surgery or for an intervention was classically taught to be 50% reduction in AHI and it should come less than 20. You understand? So supposing there's an AHI of say 40 and after an intervention by doing a very good multi-level surgery, the AHI has come to 10, from 40 to 10. So obviously, according to this criteria, it's a success. But what about somebody with an AHI of 80, and that's come down to 40? Don't you think we have made an impact on that person's quality of life or his oxidative burden? But according to this criteria, that's a failure, because it's not gone below 20. Yeah, so it's debatable. So there comes this, the sleep goal as a success criteria. There are a lot of things that are found, a lot of papers about how to holistically measure the outcomes after an intervention for OSA, but this is something that I just went through because I was fortunate to work with Dr. Kenny Pang for a few days at Singapore, and this paper speaks about 9 parameters. So the first one is a snoring visual analog score, like say from 0 to 10. The partner is asked to score the partner's snoring. Like 0 is no snoring and 10 is like horrible snoring, to the extent that probably the neighbors also can't sleep. So they are supposed to label it before the intervention and after the intervention, supposed to number it. Then you have a latency of sleep onset. Supposing we are all sitting here, and post-lunch, our sleep latency actually just goes down to even 2 minutes or 1 minute. If the speaker is silent and you just doze off. But in the morning, it's say about 10 minutes or 20 minutes, or sometimes it's not even there for the bright delegates. So roughly, it takes about 10 to 20 minutes for us to fall asleep. But if that goes down to less than 8 minutes, that means our latency has reduced. So that's another measure. Epworth Sleepiness Scale, we're all aware. Execution times, about how quickly a person can respond to a particular task or a stimulus. Looking at the blood pressure, looking at the weight reduction, and looking at the oxygenation, the improvement in oxygenation. And then A is actually the Scher's criteria, which has not been totally neglected, but has been incorporated in this, and the quality of life. So all these parameters, when you look at it, they ran a multicentric study. This was published in 2020, about 4 years back, in a Malaysian journal, and which is quoted widely in sleep circles. And we are very fortunate that 2 authors in this paper were from India, our own Srinivas Kishore sir and Dr. Chandra sir. So we are very fortunate that they have been great work, doing great work along with Vijay Krishnan sir at the international level. And it is one speciality where actually we are at the international level because of the hard work of our predecessors in the work of sleep and OSA. So what did they do? They did a 7-country trial, and they looked at the patients who underwent nose, palate, and or tongue surgery, and pre and post-operative data were analyzed based on both the conventional Scher's criteria and the sleep goal. And what did they find? So they found out that, I told you about the visual analog score, it improved, which was significant statistically. The Epworth score also improved. The BMI decreased, the mean AHI decreased, and the mean lowest oxygen saturation improved. So all these were found as a positive as a positive outcome after the surgical intervention. And the mean duration of oxygen also decreased. The desaturation, the time spent in less than 90% desaturation also decreased. So when you look at it, if you analyze this data, if you only look at the conventional Scher's criteria, the success was 66.2, but when you looked at the sleep goal, the success was 69.8%. That means more people were benefited when we use this as a measuring stick. And this is the interesting note, that if you look at only the Scher's criteria, 63 patients who had significant blood pressure reduction, 29 patients who had BMI reduction, because you sleep well, you lose weight, and 66 patients who had clinically significant decrease in duration of oxygen of less than 90% would have been misclassified as failures if it was only the conventional Scher's criteria. So to summarize, AHI is a single parameter, is unreliable. Gone are the days when I talk to the pulmonologist and the pulmonologist just talks about how much of AHI have you reduced after your surgery, or we're just discussing on platforms about AHI. But we have to grow, especially for the younger colleagues, we have to grow beyond and talk about more holistic measures about improving the quality of life. Sometimes the patient would have been referred by a physician colleague for high blood pressure. The patient doesn't know what is AHI, and sometimes even the physician is not worried about the AHI. Our focus would be maybe his diabetes. Our focus would be probably his obesity. It could be probably his high blood pressure. Yeah. So, and probably it could only be the snoring. The wife doesn't want to know what is AHI. The husband is least bothered. He just wants, the snoring to go away. So, gone are the days when we just talk and debate about AHI. Assessing true success outcomes of OSIT requires comprehensive and holistic parameters which reflect true end organ injury or function, like the sleep goal. I'm not saying that today I'm talking about sleep goal. Maybe 5 years down the we may have our own papers about certain X or Y number of criteria. And so the postgraduates can take up. We have, say, C-reactive protein. We have something of high sensitivity CRP or ESR, or we can look at, say, interleukins, TNF. There are so many biomarkers. Sorry, this was just an old slide. We just finished this pediatric OSICon. So to summarize, there's lots beyond AHI, and this was like a sensitizing topic for me to speak about. I'm not going to take much time. And thank you, Dr. Shankar, for giving me this brief slot to express my thoughts. And all the best for the coming. I hope this continues every year as an annual event. That's how it should be. And every year we make it stronger and better. Yeah. Thank you. Thank you.